Hey, I made a physical exam, just a general physical exam video for you guys. Um, if you are wanting to see it from like front to end, I think it's something that would have really helped me when I was like this time last year. Um, just a disclaimer, I am by no means an expert. I'm still a student. I'm still learning all the time. So if I did something wrong or if I said something wrong, I'm sorry. Please don't be mad at me. I think that the one thing I forgot was to do a visual fields, like testing peripheral vision. And in school, they teach you to do a static wiggle test, which I found really difficult to do properly and effectively. So my preceptor taught me a different way to do it. So if this is your patient's head, you're going to take your fingers back behind their head and slowly move them towards you. And when your patient says, I can see, like that's where their peripheral vision starts. So they should be like 180 or a little ahead. If your fingers are out here in front of your patient and they're like, oh, I can see now, like they have a peripheral visual deficit. Otherwise, yeah. Also, like if I do something differently than how they're teaching you in clinical skills, like you have to do it the way that they're teaching you at school. Like they know what they're doing, and you should be doing it the way that they say. So I don't know. If you find it helpful, great, and if not, I totally understand. I know that I would have thought it was helpful to see someone do it from beginning to end when I was a student last year. So it's a little long because I'm like talking my way through it. When you get into like an OSCE and you're doing the physical exam from beginning to end, it goes really fast if you're not talking the whole time. And I think that we were expected to do it in about 20 minutes, and it usually came out like I was always rushing through it. Like would just make it at 20 minutes. So yeah, I hope it helps, and I hope you guys have a very happy Thanksgiving. Okay, so the first thing that we do is assess our patients, just generally assess our patient. I'm going to look to see if she's dressed age appropriately, if she has good hygiene, if she has a good affect, her eye contact, her general demeanor. And then I'm going to quickly assess her mental status by asking her a few questions. So what is your name, ma'am? This is my mom, by the way.
Mary Grandfather.
Okay, and where are you?
I'm at home.
Okay. Do you know why we're here?
You're doing a physical.
I'm doing physical. Okay. And what is the date today? It's a hard one.
It's November, and it's probably 17th?
Yeah. A better thing is like the day of the week?
It's Saturday.
Good. And you know what month it is?
November.
And what year is it?
18.
Okay. It's a little easier because like sometimes we don't even know the date. Okay. And I do that at the beginning because I almost always forget it at the end. So the next thing I'll do is start my HENT exam. So I like to just generally observe my patient's head. Is there any asymmetry, any anatomical abnormalities, any obvious masses that I can see? And then I will start to palpate and look through my patient's hair. So I just look through her hair for like hair color, hair distribution. Is there any thinning or scaling of note? And then I can palpate her scalp to see if she has any tenderness. And then I will go ahead and start by examining lymph nodes. I use like the pads of my 3 fingers, and I just make little circles. And it's important to say out loud the specific lymph nodes you're examining. So I start with pre-auricular, post-auricular, the occipital, the tonsillar, the submandibular, the submental, the anterior cervical, the posterior cervical, and the supraclavicular. So with the supraclavicular, you want to pull out the patient's clavicle out of their shirt, and then you got to press like pretty hard above their clavicles to feel those lymph nodes. So while I'm still like touching my patient's face, I'm just going to do everything that involves me touching their face. So once I'm done like putting my hands all over them, I'm done. So now I'm going to assess the temporal mandibular joint. So I find the joint. Can you open your mouth for me? Looking for symmetry. You can close it. You feel any popping or clicking?
No.
Or pain?
No.
Okay, open again. Wiggle your chin from side to side. Okay, good. And then I'm going to test the muscles of mastication, which is part of the cranial nerve 5. Okay, can you go ahead and bite down? Okay, good. And then the temporalis, go ahead and bite down. Okay. And then, again, while I'm touching the face, I'll just do everything else that involves me touching her face. So can you close your eyes really tight? And don't let me open? Okay. And then open up your eyes. I'm going to look at your sclera now. So go ahead and look up for me. I'm just going to pull your lids down. And, okay, and then look down for me. And I'm going to pull your lids up. I'm just looking for you're looking at the sclera for injection or icterus, but you can also look at the bulbar conjunctiva for pallor or injection or exudates. Okay. And then so we started to do the cranial nerve 7 there as well. So I'm going to go ahead and finish that up. So can you puff out your cheeks? Okay. Can you wrinkle your forehead? Can you whistle?
You can't.
I cannot whistle. Okay. And then from here, I would go ahead and test the rest of her cranial nerve 5 as well. So we like to do sharp and dull discrimination in all 3 divisions of the trigeminal nerve. So that's ophthalmic, maxillary, and mandibular, and you have to do it on each side. So ideally I would have like a paper clip and a cotton swab, and then I show her hand. This is sharp, this is dull, and then I would have her close her eyes. Sharper, dull, sharper, dull, sharper, dull, sharper, dull, sharper, dull, sharper, dull, asking her to discriminate. While I'm testing cranial nerve 5, I can also test her corneal reflex because the trigeminal nerve does innervate the eye for the corneal reflex. So I would do this by like sticking something in her eye. I won't do that for her right now. But it's important to vocalize that. And then I would start with my eye exam. So you want to do visual acuity first because the rest of the eye exam involves a lot of like light in the eye. And she knows from the sheer amount of times I practiced my fundoscopic exam on her, like your visual acuity is significantly decreased sometimes after we do that. So I'm just going to start with a handheld card. Just going to hold it 14 inches away from her eyes, and it kind of differs between cards. It'll say on there how far you're supposed to hold it away. I have her cover one eye and read the lowest line of numbers that you can on this side.
8749.
Sure. And then she does it on the other side too. Now I'm going to do extraocular movements. So I'm going to have you watch my finger. And just don't move your head, but follow my finger with your eyes. You want to go pretty far out. And then check for convergence as well by bringing her eye in. And then I like to check for accommodation. You can do this by having your patient look beyond and then look at your finger. And the pupils should constrict whenever they focus on something closer. Now I can use the lights. Okay, so the first thing that I'm going to do is check that her pupils are equal, round, and reactive. So go ahead and look straight ahead. Just going to check your pupillary response first direct. And then consensual. Okay. And then I'm going to check her red reflex now. I do this standing a little bit further away. And you're just looking for that flash of reddish, orangish pink upon contact with that light. And then this is when you would do the fundoscopic exam. I'm not going to do it on her because I'm not super great at it and I don't want to just blind her for no reason. But you do this by looking with the opposite eye, slowly moving in and adjusting, and you want to like peer around in the eye as if it was a window, and you're looking for the vasculature, the optic disc, the macula, the fovea. You're looking for macular, like papillary edema, AV nicking, any retinal lesions, any exudates, any retinal hemorrhages, cotton wool spots, anything like that. And then while I have my light, I'm gonna move to the ear exam. Ear, you always want to look behind the ear. It's a spot that's like notorious for melanomas and skin cancers and things like that. So while you're back there, just take a look. And then I hold my otoscope upside down and I brace my hand against her head with my pinky so that if she were to like rear back or jerk towards me, I wouldn't puncture her eardrum, which would be bad. So I just take a look in her ear. I pull up on the tragus or the auricle. If she were to have like significant tenderness with palpation, that would be suggestive of like an otitis externa or something like that. So you pull up and you look inside. Help if I turned it on. Oh, never mind, it's dead. I'll just have to pretend. So you pull up and you look inside. And sometimes you really have to angle anteriorly to see, but you're looking for erythema in the canal, any significant keratinization of those epithelial cells. You're looking for any drainage in the canal, and then on the tympanic membrane itself, is it injected? Is there a fluid level? Is there any foreign bodies? Is there a cholesteoma or something like that? And then while I'm doing the ear exam, I would go ahead and test her crude hearing. I would do this by standing behind her. We'll pretend I'm behind her because I can't really get behind her right now. And I would ask her to tell me on which side she heard this noise. So you can close your eyes and then point to the side that you hear the noise. Good job. Her crude hearing is intact, so I do not feel the need to do a Weber-Renée at this time. If it were impaired, then I would do Weber-Renée to distinguish which side it was on, and if it was conducting or sensor integral. And then I would go back for my light, and I would look in her nose. I know. So it's important to lift up on the nose, make her a little piggy, and look up in the inside. You're looking for that nasal mucosa. Is it edematous? Are there polyps? What color is it? Is there drainage? Is there septal deviation? Is there erosions? Is there foreign bodies? Is there blockages? Just general things like that. And then I would move on to the mouth exam. So go ahead and open up your mouth. Just gonna look on the inside. Can you stick out your tongue? Okay, can you lift up your tongue for me? All right, and then can you show me your teeth? Okay, can you open up again? Okay, so there, I'm just gonna talk you through this. You wanna look at the oral mucosa and see if it's dry, if there's any lesions on the tongue, on the mucosal surfaces. Underneath the tongue is really important because those lesions beneath the tongue are more likely to be malignant. Aphthous ulcers, leukoplakia, Wickham striae, and then looking at the teeth themselves, is your patient edentulous? Do they even have teeth? Are their gums inflamed? Do they have dental erosions? You can tell a lot by your patient's mouth, so it's important to look inside of it. And then you have your patient say ah, and actually it helps sometimes if you have them say pa. It can help drop the tongue and you can see the back of the throat better. But when you look at the back of the throat, you want to see, first, is the oropharynx patent? Are the tonsils present? And if so, how large are they? Are they injected? Do they have exudates? Is that uvula hanging midline? Is it deviated? Is there like descent of like the soft palate? And then if there's erythema in the back of the throat, and then I'll have her stick out her tongue. Can you move it to side? And then can you put your tongue back in your mouth, please? And can you stick your tongue on one side of your cheek? Yep. And then don't let me press. Okay, other side. Don't let me press. Okay, so there I tested her hypoglossal nerve, and I also tested strength when I had her press on her cheek. And then, I'm not going to do this on her because I don't want to gag her, but you test the gag reflex, and that assesses your glossopharyngeal nerve as well as your vagus nerve a little bit. So at the end of the ENT exam, I like to just run through the cranial nerves in my head and make sure I covered all of them. So 1, I missed one, the cranial nerve 1. So this is when you like reach into your lunchbox and find that orange that you have in there and have your patient close your eyes. Can you smell this? What is it? It's a hand. I don't know. You just test their sense of smell like that. I did cranial nerve 2, I did 3, I did 4, I did 5, I did 6, I did 7, I did 8, I did 9, I did 10, I didn't do 11, so can you shrug your shoulders for me? Okay, can you turn your head that way? Okay, can you turn your head that way? No, I did 11 and I did 12, so I always do that at the end because I usually forget at least one of them. At this time, we move to the neck exam. So I'll do part of it now and I do part of it in cardio because I think there is some overlap there. First, I start by just looking at the neck generally, seeing if there's like an obvious goiter or JDD while she's sitting. And then I note the position of the trachea. You want to do this by isolating the trachea as far down as you can, because if tracheal deviation is going to occur, it's not going to be up here, it's going to be like down here. So I localize it as far down as possible. Her trachea is midline. And then I went to examine the thyroid. Most people do this from behind. One of our endocrinology teachers told us to do this from both the front and the back, and that it helps with accuracy. So I do it from the front and the back now. So I start in the front and just looking, and then I palpate her thyroid while I'm looking at it, just to help localize it, and then I will come around to the back. So I'm just going to reach around the front to your throat, okay? All right, so I just palpate here, looking for that glandular tissue, and the other side as well. And then you want to displace the thyroid by pressing on the trachea, and it helps that tissue on the other side just kind of become a little more available for you to feel. You do it on the other side, and then you stretch the skin out over the thyroid, and can you swallow for me? Okay, and you feel the thyroid lift a little bit, and that can help you to feel a nodule if one is present. Okay. So that was the neck exam. Next, I am going to, while my patient is still sitting, I'm going to start my respiratory exam. So I do this first by examining my patient's breathing. Do they have any intercostal retractions? Are they obviously short of breath? Are they hyperpnic? I hate saying that word. And then I will do a diaphragmatic or chestal excursion. So take a deep breath in and out. Okay. And here you just place your hands on the chest. They take a deep breath in and out. You want it to be symmetrical. If your patient's chest wall goes like this, they could have a phrenic nerve palsy or something that is preventing the symmetrical excursion of their chest. And next, I'm going to do diaphragmatic descent. So this one, you are going to percuss and feel or try to hear where the diaphragm is. A normal diaphragmatic descent, I believe, is 3 to 5 centimeters. Although in a really healthy person, it can be higher than that. So I'm gonna have my mom take a deep breath in and just hold it. Okay, take a deep breath out and hold it. Okay, and you're listening to where that lung field ends at both exhalation and inhalation. Like in an ideal scenario, if you're super concerned about this, they're going to be wearing a gown, and you can mark where that point is and measure it with your measuring tape. Okay.
What's mine?
I didn't measure, so I don't know. She wants to know if she's really athletic. Okay. So now I'm going to listen. I think at school they want you to listen to 14 spots total. I'm not going to have her take a full breath in and out because that can make her lightheaded. But it's important that in like a real exam you do that. They get a big breath in and out. Okay. And you want to move along those 14 points in like that ladder distribution that they talk about. So that you can compare sides. And it's also important to get the basis of the lungs on both sides because remember the lungs kind of fan out like that. And then we will percuss the lung fields on the back. I percuss with this thing because I don't know how to do it regularly. Okay, so next I'm going to have her lie down at 30 degrees. That's why I have these pillows. Hopefully it works out. Okay, so now I'm just going to listen anteriorly. You want to listen to the apices with the bell. And this is a really good place to hear. And with the bell, it's important to have like direct contact with the patient's skin because you want to like seal off over the area you're auscultating. So take a deep breath in and out. Okay, and the same thing on this side I would do. And then I would flip around to the diaphragm and listen in those areas over her anterior chest wall. Okay, and I believe they want you guys to percuss the anterior chest wall too. I have my patient turn their head to the side because it can be kind of scary to have this thing coming at your face. Turn your head that way. Okay, turn your head this way. And put your hair back when you do a physical exam so it doesn't get in your patient's face. Okay. All right. Now that my patient is in a semi-recumbent position, I can finish out my neck exam. And you do one of the things you want to do is to measure JVD. So you would look. It's helpful to have like your pen light. The tangential lighting is good to see those pulsations. If it's present, then you are going to want to take your measuring tape and measure where it is above the right atrium. And then you take your like a flat surface marker to see how like the angle at which it comes across. So you're basically measuring the height like this. And she's like a little bit low to be doing this right now. It's better if she's like at a real 30 or 45 degree angle. So you measure that. And then I'm going to listen for a carotid bruit using the bell. So go ahead and turn your head that way. And just don't breathe for a second. Okay, turn your head towards me and just don't breathe. Okay.
Do I have one?
No, you don't have one. Although you need to get your last done. Okay. And then now begins our cardiovascular exam. So I'm going to begin by, like, ideally your patient is in a robe and you're observing their precordium, and you're going to look for any obvious chest wall abnormalities, like a pectus excavatum or a barrel chest. And then you're just going to observe the precordium for, like, lifts and heaves, and then you're going to palpate. So using like the heel of your hand or like the flat surface of your hand so your patient feels more comfortable, you're just going to feel over those four classic like auscultating areas. Okay. And then I'm going to listen. So first with the diaphragm, at the second intercostal space on the right side, second intercostal space on the left, third intercostal space on the left, fourth intercostal space on the left, and then the fifth intercostal space at the mid-clavicular line. And sometimes when you're examining a female patient, you'll have to ask them to lift up their breast in order to accurately listen to that spot. It's really not weird. Every patient that I've ever sent that to is like, yeah, sure, whatever. So would you mind lifting up your breast for me so that I can listen to your heart?
I would.
You would?
No.
Okay, that's fine.
Really, there's nothing to live.
What?
This one?
Yeah. Okay. And then you do the same thing. You listen to all 5 of those spaces with the bell as well. And then you want to palpate the PMI, the point of maximal impulse. So a lot of times when people listen to the like the mitral spot, they tend to want to listen like over here. If your PMI is on your anterior axillary line, that's not normal. Like the normal place is mid-clavicular line. It will usually be like on a woman right beneath the breast. So it's very like natural to want to listen over here, but it's really mid-clavicular line. And then while I'm doing my cardiovascular exam, I'm going to do pulses, and you want to do these on both sides, but as long as you vocalize in the exam that you would do both sides, I'm pretty sure that's just fine. So we're going to do the radial, the brachial, the carotid. Always do the carotids one at a time. We would do femoral, going to do popliteal. Oh, you can put your foot down. Thank you, though. She's so helpful. Dorsalis pedis. And posterior tibial. And again, we would be doing those bilaterally. Okay, and now I can go ahead and move on to the abdominal exam. So I'm going to have you lay back flat. Oh, shit, sorry. Do you have to shoot? Sorry. I'll get you a lollipop when we're done. Okay, so now with the abdominal exam, you're just going to begin by observing your patient's abdomen. Do they have, again, any obvious anatomical abnormalities? Do they have a scaphoid abdomen? Do they have a particularly protuberant belly? Do you suspect ascites? Do they have a caput medusae? Do they have any large protruding masses? Also, like, if they have a scar, ask them about it. Your patient will come in with abdominal pain, and they'll report no surgeries, and then you get to their abdominal exam, and they have like a linear scar down here, and you're like, oh, what was that from? And they're like, oh, I had my appendix out when I was 12, and now you know that you don't need to be concerned about appendicitis. So again, we begin by just observing, and next we want to listen. So with the bell, you're going to listen for an abdominal bruit. You're going to listen for renal bruits on either side of the umbilicus, superior aspect. And then you can listen for iliac bruits on either side of the umbilicus, inferior aspect. You can also listen for femoral bruits here. Then we want to listen for vowel sounds in all 4 quadrants. If you want to be sneaky, you can like listen and then slowly press into your patient's abdomen and watch their face and see if that like coincides with their tenderness upon palpation in their exam later. But we want to listen in all 4 quadrants for vowel sounds. And then we want to begin our palpation. Some people do this in a different order. I think that the program has you do it, the abdominal exam specifically, in a different order. So do what they tell you to do. So first is light palpation. So this is pretty much to elicit tenderness. So when you're doing this, you want to be watching your patient's face, because if they're wincing, you want to see it. So, and again, start in the quadrant adjacent to the one they're complaining of pain in. Ow! All right. It didn't hurt whenever I auscultated, so I don't believe her. Do you have any pain? Any pain here?
No.
Any pain here? Okay, next is our deeper palpation. We put one hand over the other, and this time you're kind of feeling for masses, so you want to dig in a little bit deeper. It can be a little bit uncomfortable for your patient. Cool, okay. And then you want to percuss in all 4 quadrants. And then we can do these more like specialized organ percussion and palpation. So first we'll do the diaphragm or the liver. When you're measuring the area or the span of the liver, either have your patient breathe in or have them breathe out. You just don't want them breathing in and out because the diaphragm moves with movement and it moves with breathing, and it's difficult to measure the span of it while they're breathing. So take a deep breath in. Okay, and you want to do that mid-clavicular, you can breathe now. You want to do that mid-clavicular line. I believe a normal diaphragm or liver span is like 6 to 12 centimeters. I think anything greater than 15 is pretty concerning for hepatomegaly. And next I will do the spleen. So there's a couple ways to do this. First, you can do Castell sign. So you come to the anterior axillary line, right below the costal margin, and you're listening for tympany because this is where the gastric bubble lies. If you take a deep breath in, it was still tympanic. You can breathe, sorry. It was still tympanic whenever I did that, which means like if it were to become dull, that would be the spleen, the enlarged spleen shifting down over that space where the gastric bubble was. The noise would become dull, and this would be suggestive of splenomegaly. I believe that's Castell sign. The other way we can do this is to kind of percuss over the area of Traub space. From what I remember, I believe Traub space is supposed to be tympanic, and if it is dull, it's suggestive of splenomegaly. I'm not completely sure about that. So we'll come over to Traub space. We're going to find the, I believe it's like the 8th rib along the costal margin into the anterior axillary line. So that was the spleen. And now we can palpate these areas. So I like to stand on the opposite side of the organ that I'm palpating. With the spleen, I reach around with my left hand onto her lower ribs, and I kind of pull her rib cage up to like dislodge the spleen if it were to be there. And then I come with the other hand right below that costal margin, and I'm just feeling for the spleen. If you feel the spleen at all, from what I remember, it's likely enlarged. Like I don't think you should be like hanging out with your spleen. I did not feel yours. And next we'll do the liver. So I like to come around the other side. I can't come around to the other side of her right now, but with the liver, you're going to have your patient take a deep breath out to move the liver up. You're going to press your hands below their ribs, below where the liver is, and then you're going to have them take a deep breath in. And as they breathe in, the liver should come down and tap your fingers a little bit. So I'll show you. Take a deep breath out. Okay. And then I'm going to reach under her ribs, take a deep breath in. Okay. And there's her liver edge. People describe it like they say that you can feel like a quality of the liver, if it's nodular or sharp or smooth. I feel the liver. I don't really know what the other stuff is. I'm just lucky to feel the organ. And then the last thing with the abdominal exam, after we feel for inguinal nodes, which you want to vocalize, we're going to do the abdominal reflex. You take the end of your reflex hammer and you brush along the abdominal muscles, and you should see like a little bit of a contraction for the abdominal reflex. After I do that, I have my reflex hammer in my hand, and it reminds me to do reflexes. So go ahead and help your patient sit up. You got it? Okay. So with the reflexes, we're going to start with this one, brachioradialis, this one. So you have your patient relax with their arm resting on their ulnar aspect with the flat side of your reflex hammer. You just tap over their muscle, and you should see like a lateral twitch with their arm. Next, we're going to do the, you can relax your arm. We're going to do the biceps. So if you're ever having trouble finding the biceps tendon, just have your patient like flex your bicep. She is so strong. And it's much easier to find it after that. So just put some pressure over that tendon, and again, with the flat side, tap your thumb, and you can feel it flex. I think that one's pretty easy to find. And then the triceps, go ahead and hang your arm, like put the weight of your arm into my arm. And this one is like, it's hard to get patients to like relax. You'd be like, chill. With this one, I take the sharp edge of the reflex hammer and I tap over the triceps tendon, eliciting a twitch. And then we'll do the patellar reflex. Can you uncross your legs for me? You find the patellar tendon, again with the sharp aspect of your reflex hammer. I think I saw it. Yeah. And again, we would be doing this bilaterally. And then the last one is the Achilles. So this one, you're going to have your patient hang their foot, and you're going to reach underneath the ball of their foot and lift up just a little bit. You want them still relaxed, but you just want to put a little bit of upward force on their foot, and then with the flat aspect of your reflex hammer, tap the Achilles heel from the back, and you should feel them press down a little bit with their foot. While I'm down here, I'm going to do a couple of things. I'm going to check for peripheral edema by squeezing her legs and seeing if there's any pitting or non-pitting edema. You don't have any edema. And then I'm going to start to test muscle strength while I'm down here as well. So can you lift up against my hands? Can you press down into my hands? Just trying to show me how strong she is. Can you press out with your legs? Okay. Can you lift up against my hands? Okay. Can you go like this? Don't let me pull away from you. And don't let me push towards you. Okay. Go like this. Don't let me squeeze your fingers together. Okay. Can you lift up against my hands? Okay. And then can you go like this? Don't let me break your fingers apart. Good. While I'm looking at her hands here, I can look for capillary refill. You can stop being so zen now. So with the capillary refill, like she's got these acrylic nails, I would be like, oh crap, I can't see anything. Just flip her hand over and do it on the pads of her fingers. It basically works the same way. And then you can tell a lot about your patient by their hands. Do they have like lesions? Look at their fingernails for like Hutchinson's sign. Paronychia, phelon, calluses. Look at the palm specifically, especially in African American patients. This is where they develop melanomas as well as on the sole of their feet. You can look for hyperlinearity, palmar erythema, and pallor within the creases of the hands is suggestive of anemia. When you do those muscle testing, it says on the rubric like temperature and color, so vocalize that. You're looking for cyanosis and like cold extremities when you do that. Are you cold? Okay, and then we're gonna finish up with a neurological exam. So just like we did the sharp and dull on her face, testing the trigeminal nerve, we want to do that on her hands, on her trunk, and on her lower extremities as well. So close your eyes. Sharper dull, sharper dull, sharper dull, sharper dull, bilaterally. We also do 2-point discrimination. So I would take like a paper clip and like slowly move the points further apart, and on her, like the pad of her finger, like close your eyes. 1 point or 2. 1 point or 2. So you know the distance at which they can differentiate 1 point from 2. We also want to do vibratory sensation. So start on the most distal digit or joint. Can you feel this? Okay, so if she were to say no, you move up proximally until she can. Can you feel this? Really? We'll investigate later. So that's vibratory sense. And then we also want to do proprioception. This is important on your patients that have diabetes. So we're going to say, so this is the up position, and this is the down position. So I want you to close your eyes and tell me if your toe is up or down.
Up, down, down, up, down.
Okay, so that's your proprioception. And then a couple more neurological exams we can do. We can do graphesthesia. This is where you draw a letter or a number into their hand and see if they can recognize what it is. So can you tell me what this number is?
2.
Good. Can you close your eyes?
Very close.
Oh, good. Okay. Can you tell me what this is?
It's that thing you just.
Not stereognosis. So that was stereognosis. And I mean, the patient's not going to recognize
The hammer.
reflex hammer. Yes. So you hand them a familiar object. It should have been like a pen or I don't know, something that they can recognize. You hand to them and see if they can verbalize what it is with their eyes closed. And then while you're sitting, can you put your hands out, touch your nose, other way, touch your nose. So she has no dysodyskinesia. Can you rapidly do your hands like this? Good job, you look great. Can you do, run the heel of your foot along your shin? Okay, good. And then can you put your hands out like this? Close your eyes. And you're looking for pronator drift here. So if she were to go like this, I'd be like, oh crap. But she's not, so we're good. Can be done with that. And then the next thing we're going to do, I'm going to have her stand up. Good job. When you are doing your standing neurological exam, I always do a Romberg first, because if they can't do a Romberg, I'm concerned about them hopping on one foot. So go ahead and face this way. You can put your feet together, and then your arms by your side. Your patient is going to do this. They can't do this because they can like brace themselves. They have to have their hands at their side. Close your eyes, and if you fall, I'll be here to catch you, but you just want to watch to see if they're swaying at all, and she's not, so she's good. That's your Romberg. The next thing I'm going to have her do is a shallow knee bend. Can you do a little bend? Good, that was good. So if your patient is sitting in a really deep chair and they stand up, you can count that as your shallow knee bend. Can you hop on one foot? Other foot? Good job. Okay. Can you walk that way? Just normal? Okay, can you walk back this way with your heel to toe walking? Okay, can you walk back that way on your toes? Pretty. Can you walk back this way on your heels? Cute, okay. And then this is where I always stop to remember what I forgot. So while she's standing, I'm gonna do a quick back exam. I'm gonna assess for CVA tenderness. So you place, here you can turn this way. Place your hand on her back at the costovertebral joint, and you just hit on her back like this. I've had a kidney infection before. If it's there, it really hurts. And then I'm going to assess her back. I'm just going to palpate her spinous processes, see for tenderness. And then can you bend to one side? Can you bend to the other side? Can you bend back a little bit? Can you bend forward? Okay, bend forward all the way for me. And you're going to assess here for scoliosis. You can look and see if her spinous processes are straight. Okay, go ahead and stand up. I don't know, did I forget anything?
I don't know.
Probably.
I think I'm perfect. Except for the toe thing.
Well, we're going to investigate that.
Yeah, what does that mean?
Well,
You're welcome.